So I'm here today, like Dr. Sabando told you, to talk about alternatives to opiates for pain management. And in case you haven't read the newspaper recently, we're having some trouble with opiates in our country. So during residency, I dealt with the acute pain patient, I dealt with the chronic pain patient, and you deal with the opiate overdose patient. So a whole spectrum of opiate issues. And towards the end of my training, I realized that maybe since I felt there was a need, I could learn a little bit more about it, and what it turned into was a fellowship, which was wonderful. And from the fellowship, we were able to build a program at our institution, and I'm going to talk to you a little bit about that today. So the trouble with opiates is there's a lot of addiction, there's unwanted side effects, and also I think that they've become a first-line medication when they're really not a first-line medication for a lot of what we see. The Center for Disease Control has talked about recently that this is now an epidemic. This prescription opiate overdose has gone to epidemic proportions. Young people are dying. They're dying at terribly large numbers, and you can see here, they are dying upwards of 29,000 deaths per year. So these are young Americans. This is our future of the country, and they're just dying at ridiculous numbers. For women's health, it's become a huge crisis. About 20 women die every day from prescription opiate overdose. And more women have died from prescription opiate overdose than motor vehicle collisions. And almost 1 million women a year are being seen in the emergency department for drug abuse or misuse. So these numbers are staggering, and this is a very important topic that goes across all specialties. Your opiate prescribing habits matter, and why is that? Because Vicodin is the #1 prescribed medication in the country, which is a little silly when we think about, we just had a beautiful endocrinology discussion, and we think about the hypertension and the diabetes that we see. Why is it Vicodin? And I think that it started off with well-intentioned prescribing for pain. Opiates seemed like they were okay. There's some miseducation in the 80s and 90s. And I think it started off, again, well-intentioned, but it's certainly gotten away from us. 4 out of 5 new heroin users state that they started on prescription opiates, and they only moved on to heroin when they couldn't get the prescription opiates anymore. So the problem is our prescribing of opiates, well-intentioned, may lead to heroin and may lead to death. The prescription opiate epidemic is being looked at. It looks similar, actually, to an infectious disease. So when we look at the rising rate of young Americans dying, it looks like AIDS in the 1980s and 90s. A steady, alarming, exponential rise in deaths among young Americans. Actually, the discrimination by physicians on people of color, African American and Hispanic populations, has protected them from this epidemic. So we were discriminating, we were not giving opiates to African American and Hispanic patients. We were giving it to all the young white people. Well, young white people got addicted, and young white people are dying. And so are Hispanic and African Americans, just not at the alarming rate. They were protected by this discrimination. So that's good in a way. When we look internationally, we are really the only country with this problem. When you look at what percentage of the world lives in Canada and what percentage opiates are consumed, these numbers are okay. So Europe has 11% of the world, and they consume 28% of the opiates. The United States is 5% of the world's population, and we consume 56% of the world's opiates. That's a lot. When we talk about what kind of opiates are out there, every man, woman, and child in the United States can have a bottle of opiates. When we look at Japan, every single year, every person in Japan will get about 26 milligrams of morphine. In the United States, every man, woman, and child would get 663 milligrams of morphine when we look at all the opiates we're prescribing. So again, we're doing a little bit too much prescribing. So I am not saying stop using opiates. I love opiates. I think they have a huge place in the management of pain, especially acute pain, especially abdominal pains, but not for everything. They're not first line, and we really have to start looking at alternatives because young people are dying. This is an epidemic. This is a huge problem. And if we don't have a proactive, innovative strategy to fix it, everybody's just going to continue to die. So let's stop the dying. So what did we say? At St. Joe's, we said, let's start up front, and let's try to prevent opiates from being prescribed if there's effective alternatives, And in doing so, we can stop that downstream effect of addiction, dependency, and maybe moving on to illicit drug use. So what we fondly call our program is ALTO. It stands for Alternatives to Opiates. It took about a year or two to formulate. I was going through my fellowship when we started talking about it with my chairman, Dr. Mark Rosenberg. And it went live January 4th of this year. We've had a couple hundred patients go through the program, and we've had staggering success. The idea of this concept did start with a physician out of Maimonides. His name is Dr. Sergey Matov. He's been a huge educator in regards to opiates and physician education, and he did start this movement. The goal of this program is just to utilize non-opiate medications in conditions we know there's evidence that non-opioid medications work, utilize other modalities like trigger point injection, nitrous oxide. Just let's take a look in our toolkit and see what else we can use. We also wanted to focus on patient education. So if you look at some of the studies out there, patients get an opiate prescription, and we may tell them a few things, may cause nausea, may make you sleepy, don't drink alcohol, don't drive. But do we tell them that in a percentage of patients, they get addicted? And they feel the craving for it, and they feel the craving for more? Do we tell them? So part of the ALTO program is to educate our patients, empower our patients to know, but also really focus on the alternatives. The CERTA concept is basically, let's utilize every other thing besides the mu receptor, channels, enzymes, receptors. And what that means is we have a variety of medications that work synergistically. Instead of just one tablet of oxycodone or Vicodin, let's go ahead and agonize or antagonize a couple different receptors, use a variety of these medications, and see if we can get the same pain relief. So this is not, again, for every patient. Patients need opiates. Patients are important. Opiates are important. But there are conditions where we have evidence, so that's what we're going to talk about now. These are the 5 conditions that we identified in our ALTO program that there is some literature that we can use non-opiate modalities. And the first one we'll talk about is renal colic. So for renal colic, this is our algorithm here. I'm sure this is something that you've seen, maybe even experienced it yourself, the first 3. But the last guy here, cardiac lidocaine, is something a little bit new. Not new to the world of medicine, but relatively new for the treatment of renal colic. If we look at some of the early studies, in 2004, there were studies looking at chronic intractable cancer pain. So these patients are on drips of morphine, drips of Dilaudid, they're sedated, they can't interact with their family, the constipation is intractable. So how can we help them? These early investigators started doing a lidocaine drip on these patients, monitored their pain, monitored their side effects. And patients who received a lidocaine drip had better quality of life, decreased pain scores, and they didn't really see much toxicity. This was then translated for acute postoperative pain. And again, patients had reduced pain at rest, reduced pain with movement, reduced nausea, decreased length of stay, and again, not much toxicity. So there was a Cochrane review done on this. And really, the findings were quite nice. Decreased pain, increased function, decreased length of stay in the hospital. And again, we're not really seeing a lot of the arrhythmias or a lot of toxicity that concerns us, as it should, about lidocaine. But in a lot of these patients, we don't see much. We just see some good pain relief. In Iran, they do not have access to intravenous anti-inflammatories. So for renal colic pain, where we know we reached anti-inflammatories as first line, in Iran they're left with really opiates. So the investigators in Iran said, well, let's take a look at this and see if we can translate this into renal colic. So they did a few case series and their results were compelling. So they did a randomized control study and found that when you compare 1.5 milligrams per kilogram of cardiac lidocaine versus 0.1 milligram per kilogram of morphine weight-based, they actually have better pain at 5, 10, 15, 30 minutes. The adverse events were the same. Without side effect here, 87%, without side effect, 86%. And you can see the side effects are similar, a little dysarthria that's transient versus the vomiting, so nothing significant, no severe toxicity, no intervention necessary. The hypothesis behind this is that by anesthetizing the ureter, you're actually just decreasing the afferent pain fibers from firing and from having any kind of pain associated with your stone. They also believe that by paralyzing the ureter, the understanding is that the stone may actually flow distal a little bit quicker. So in summary, for renal colic, there is compelling evidence that intravenous lidocaine is a good alternative. You go ahead and, if possible, use your Toradol, use your Tylenol, and your fluids. in a patient who does not want opiates or you're concerned about giving opiates, this is just an alternative. If the patient does not have adequate relief at our hospital, then we will move on. And of course, we want our patients to be pain-free or have pain that is tolerable. But this is what we do to start. Lumbar radiculopathy. So your patient comes in with sciatica pain, and they're hard. They're in a lot of pain. It's neuropathic pain. It's searing down their leg. It's terrible. So what do? We start with Tylenol, ibuprofen. If they're not on a muscle-relaxing medication like Flexeril or Valium at home, and you feel there is a component of spasm, you do also want to add that on. And we'll talk about a little later trigger point injections. Fantastic intervention to get to the generator of pain in a lot of these patients. Also gabapentin. In the emergency department, some of us are reluctant to start gabapentin. We may not have been used to using it in training, but it's actually a very good medication. It has relatively few side effects, and it's nice to start patients on something that may help to decrease the pain associated with nerve irritation right in the ER, and then let them follow up with the primary care physician, let them titrate if they feel appropriate, but at least get the ball rolling. So part of the lumbar radiculopathy algorithm is to give them a loading dose of about 300 milligrams. You can go up to 600 milligrams. Side effect will be some sedation. Corticosteroids, there are some studies that show that there's a risk, but you also have to, of course, remember, a benefit, but you also have to, of course, remember the risk. So corticosteroids may have a place for lumbar radiculopathy. And then lidoderm patch. We have lidoderm patches stocked all over our emergency department. We frequently run out of them. Put them in the area where the patient has most pain. There are studies that show that it increases functionality and it does decrease pain. There's also, I think, a placebo effect to a patch. You see this nice big patch. You put it on. It's a little cool when it goes on. They leave it on for 12 hours. So the studies are there. They're weak studies, but it's another tool. Not many side effects. About 15% of patients may have some mild dermal irritation, but it's a good tool to use. And lastly, some of your lumbar radiculopathy patients may be on opiates. They may be seeing pain physicians, and they may be appropriately on opiates. And they come into the ER with a flare of pain, and they're crying for the Dilaudid. And that is fine. There are patients who are going to get IV opiates. But in patients on really high doses of opiates, to give them more opiates is not doing them any good. Their brain is completely saturated. The mu receptor is saturated. And more opiates just leads to hyperalgesia, central sensitization, allodynia. So there's side effects as you keep bumping up these opiates. So adding something like ketamine, which is an NMDA receptor antagonist, will quiet down all that neuroexcitability and may actually get you really nice pain relief in patients who are on chronic opiates. So keep that in mind. Moving on for acute headache and migraine. If you didn't know, opiates and headaches are bad. So there's a lot of studies out there. They're really not as effective as standard migraine medication. They can actually make migraine medications like triptans less efficacious if you're giving them. They can promote chronic migraine relapse, and patients on opiates for migraine have more frequent ER visits. Also, opiate-dependent migraine patients have anxiety and depression, are just not as functional as other migraine patients. So if you have patients and you're not sure where to go with their migraine, it is not opiates. The only group that should be getting opiates for migraines are pregnant people, pregnant ladies specifically, I guess, because there's really not much else they can take. So that's the group where you say, I've exhausted everything else. All right, let's try a low dose. Let's meet frequently. Let's talk. But everybody else, really, we need to be doing something different. So the Cleveland Clinic looked at their prescribing habits for opiates and migraine in the ER, and they weren't great. They knew they shouldn't be giving them, but still 66% of patients in the ED received opiates and 44% went home with scripts. So Cleveland Clinic looked at the evidence, they built an algorithm, and after algorithm implementation, they had beautiful decreases in their numbers. Patients were satisfied, their pain scores were low, and everybody was happy. So how do we do this? Typical migraine cocktail to start off: Toradol, Reglan, sumatriptan. I don't see a lot of emergency rooms using sumatriptan, but it's a really good medication. It's best used if the headache's been going on for less than 24 hours, but can still be efficacious given later. If you give it subcutaneously, it will just work a little bit quicker than you give it PO. You can repeat it 1 hour later, another 6, if it doesn't work. So you're giving a total of up to 12 milligrams. If they do not have more than 50% pain relief, or they're reporting their pain is not tolerable, then you're going to move on. If they do say, you know what, doc, I feel good, then you're done with them and they go home. So if they have to go on to the next step, then you're looking at dexamethasone. Some of the studies say 4, some say 8. You do a single intravenous dose. It will decrease relapse. You also use magnesium, 1 milligram IV. And lastly is valproic acid. Valproic acid is not something I had learned that I could use for migraine. I heard about it here or there, but it actually is a fantastic medication. I'll talk about the evidence in another slide. But that's the last medication in that second tier. If they feel good, then they go home. If they don't, there is one more step. Haldol, 5 milligrams IV. So I know that there's a little bit of squirminess when we talk about giving 5 milligrams of Haldol IV. But we use it in oncologic patients. We use it at end of life. They should be on a cardiac monitor. You can get a screening electrocardiogram. But Haldol is a fantastic medication for intractable vomiting, and it also has beautiful relief for migraine pain. If you've gotten all the way to this point and your patient is still not feeling well, then maybe it's time to go ahead and take a step further and see what else we can do. Just giving opiates at this point, I think, doesn't do the patient justice. They've gotten a ton of medication. Something might be brewing. Let's get neuro involved. Let's keep them overnight observation status. A lot of the patients who were in observation status from Cleveland Clinic didn't end up getting opiates. The medications were titrated, played with. They got good follow-up. It plugs them in a little bit better. So opiates are not they don't diagnose what's going on. They just put a Band-Aid on it. So we need to maybe take a step further with headaches when we're going all the way to opiates. Something that I advocate for is feeling and the neck and touching our patients, which I know as osteopathic physicians we are comfortable doing. So go ahead, feel what's going on. Do they have a spasm? Is there a trigger point? Is there something we can do in terms of topical, like a lidoderm patch, or a trigger point injection, which again, we will get into. And then Tylenol. There are studies that show adding Tylenol to anti-inflammatories, the patients have lower pain scores than if they used NSAIDs or Tylenol alone. So adding Tylenol when it's not a contraindication for your patient may actually give them some relief when it works synergistically. Corticosteroids, again, risk-benefit discussion. If the patient has chronic migraines and they say, doc, it's going to come back in 24 hours, then go ahead, give them a steroid. If the patient has uncontrolled diabetes and they have no PMD, let's not do that. So it's something that you can use when appropriate. And valproic acid, there's actually Cochrane reviews on valproic acid for migraine, and the number needed to treat can be 3 to 7 based on your study. So valproic acid is a good migraine medication. Keep it in mind. It may actually be more efficacious than sumatriptan. Musculoskeletal pain. So we see a lot of musculoskeletal pain in all fields of medicine. And there's a lot that we can do with it that's non-opiate. So again, our ibuprofen with Tylenol, studies show they will work better. Naproxen is one of the safer anti-inflammatories, and it's just a twice-a-day dosing with food, so it's easy to be compliant, and you can add that Tylenol on every 4 to 6 hours. Flexeril, if the patients are not on any muscle-relaxing medication and there's a component of spasm, you can start them on Flexeril. If they failed Flexeril, you can try Valium, but again, with education that it can be potentially addicting. Lidoderm patches. You could put them all over the body. You could put a max of 3 on, and they stay on for 12 hours. You peel it off for the next 12, and then you could put a new one on. So lidoderm patches are fantastic. Trigger point injections, we will get into. And then intranasal ketamine. So back to ketamine. If you don't want to place a line, you don't want to have to worry about how much you're giving or the weight-based dosing and dripping it in and nursing, atomizers are fantastic modes of administration. If you do not have atomizers where you work, atomizers are great. You can use them for a variety of medications, and ketamine is one. You don't have to have a line in. It works quickly. It's a low volume. And again, if that patient has chronic musculoskeletal pain, they're on opiates, adding the opiates is not going to do them any good. So instead of worrying about not having your IV, go ahead and use an atomizer, and you can use a 0.5 milligram per kilogram of ketamine intranasally. You can repeat it every 20 minutes. We actually have been using it for fractures, for Colles fractures, when they kind of manage to get into our fast-track urgent care, and the patients actually do quite well. I followed up on a handful of them, and they report that their pain is controlled. They felt a little emotional, but their pain was controlled. Joint pain, similar algorithm for musculoskeletal pain, but I want to remind us to go back to some interventions that we might have learned back on rotations and ortho or when we were with PM&R. Let's remember our joint and soft tissue injections. They're very easy to do outpatient. They're very easy to do in the emergency department. Pills are easy. They're really easy, but unfortunately, they're too easy. The patients take the pills, they feel good, you feel good because they feel good. But it's gotten away from us now. The pill popping is not the answer. And I think we all feel that way. So doing an intervention like biceps tendonitis or doing a bursitis injection, let's revisit those techniques. They can be very, very effective. They may take a little more of our time, but they will benefit the patient in the long run. Last thing we'll talk about is extremity fracture dislocation. So ideally, in the emergency department, what would be wonderful is the patient rolls in with their fracture, they get some nitrous oxide, you could do some intranasal ketamine. This is all while you're setting up with your IV and you're setting up, hopefully, for your ultrasound-guided regional block. So a lot of physicians across the country are doing nerve blocks, are doing it preoperatively, postoperatively in the ER. It's a fantastic modality. You get focused, quick pain relief. The trouble is training all the staff and the resources, but if it's something that you're interested in, there are courses all over the country at most national conventions now, and you can learn this skill. If you have any savviness with an ultrasound, it's not far from doing an ultrasound-guided central line. So this is a modality, just think about, it does wonders for patients who are in pain. Little controversy about discharge medications for extremity fractures. My goal is to send the patients home with Tylenol and naproxen to explain about immobilization, to explain about elevation and ice. I know that's crazy. I know there might be riots. I hope not. But again, we're in an opiate epidemic. People are getting 60 tablets of oxycodone for their ankle fracture. They're probably taking only 5. And then the oxycodone's in the medicine cabinet, and the 13-year-old has access to it. The fastest growing population of prescription opiate addicts, 12 to 17-year-olds. Where do they get it? Friends and family's medicine cabinets. So if patients fail this treatment, they still have a lot of pain, you can give them a couple tablets of opiates, but let's at least try something different. And I'm not insane. In Holland, this is standard of care. If you can see here, that inpatient ankle repair, 98% of patients in America get opiates, which I would say, yeah, that makes sense, okay. 64 in Holland, and only 6% go home with it. And these orthopedic physicians state that the patients do well, the patients are functional, less constipation, they get back to work. Nobody's rioting. I think people are happy in Holland, as far as I'm aware, and they don't have a prescription opiate epidemic. So just something to think about. The modalities that we'll get to, this is the last piece of the lecture, are trigger point injections, ultrasound-guided nerve blocks, and then we'll talk a little bit about nitrous. So what I mentioned earlier about ultrasound-guided nerve blocks, they're focused, they're easy, they're quick, and you can do it for extremity reduction. If you need to get that joint back in, you could use something like lidocaine, it works quick. And if it's a fracture and you want to have pain relief for hours, then you can use something long-acting like ropivacaine. There's a lot of great free videos out there on YouTube. So you can do them you could do brachial plexus or femoral nerve blocks, but you can even do radial ulnar nerve blocks, very superficial, tiny little bit of local anesthetic, and you can have wonderful anesthesia for lac repair or for a simple reduction. Trigger point injections. So this is one of my favorites. Trigger point injections have taken off in our emergency department more than I thought. And it's because they're good, they work, and they're an intervention that gets to the root of what's going on with the patient. So a trigger point is an area of focal spasm, as we probably learned in our osteopathic training in OMT. And you can really feel that there's kind of a lump or a taut band, and it's very sore, and the patient's telling you, yeah, that's where my pain is coming from. My whole back hurts, but I think that's the spot. That is something that you can treat. You can use osteopathic manipulative treatment. You can also do trigger point injection. So part of the trigger point injection is to dry needle. And what that means is you've identified that spasmodic area that's causing a lot of pain. You take a small 25 gauge needle, you elevate that trigger point up in between your fingers, and you do some dry needling. What that looks like, sorry, I'm skipping ahead. What that looks like here is identifying that trigger point, elevating it between your fingers. You put a small needle into that trigger point. You may get a jerk or a twitch that the muscle is starting to release, and then you move around the clock, go around the clock a couple times with the needle, and then you give about 1 to 2 cc's of local anesthetic. Some people use steroids in their trigger point, and that's fine. It will just prolong the anti-inflammatory side effects. And the studies show that it really does increase patients' ability to move around and function. It decreases their need for additional analgesics, and this pain can be relieved up to about 4 weeks, and you can do repeated trigger point injections as necessary. So we talked about that. Sorry, these slides. The last thing I do want to mention, this is really all you need. So 25 gauge needle, 1 to 2 cc's of local anesthetic, a Band-Aid, you consent your patient, and that's it. You move on. The one thing I'll say about trigger point injections is patients have immediate relief if you get a trigger point. So you give an anti-inflammatory, you give Tylenol, you're waiting 30 to 60 minutes, you're hoping it works, you tell them to go home to continue to take it a couple times a day. The trigger point, if it's a trigger point and you get it, they really feel good. They get a jerk and then it relaxes away and they really don't need much else after that. So it's a very easy skill. Again, YouTube has some videos on it. There's not many side effects, and again, it's relatively safe, and it's something that will really help, and it will help immediately. Last thing is nitrous oxide. So this is our Director of Medical Toxicology, John Kashani, who I believe will be speaking to you tomorrow. And he was so kind as to volunteer to be our nitrous oxide model for our nitrous oxide training, and it was very silly. So nitrous oxide is a fantastic anxiolytic and analgesic. It's administered via a nasal hood or a full face mask. And the most common people to use it are oral maxillofacial surgeons and dentists. So we should use it. If dentists get to use it, we need to use it. It works really well. It's absorbed into the pulmonary vasculature. It takes effect in about 30 to 60 seconds. And when you turn it off, it's out of the system in 30 to 60 seconds. So why not? It works well when you're using local analgesia or whether or not you need to put an IV in. It helps with the children when you need to get them calm so they can get a line or they could do a blood draw. And you really don't need any NPO requirements. You don't need to worry about is the patient driving or not, and you also don't need to have access unless you're getting it for another reason. All you need is a pulse oximeter. You put the gas on, you titrate the gas up. It's great for a variety of different painful conditions. They're using it a lot in labor, they're using it for colonoscopy, bronchoscopy, and also in the pre-hospital setting. The devices that they make now lock out at 30% FiO2, so you give up to 70% nitrous and you're never without oxygen. You always have the 30% FiO2. Lots of mobile devices, easy to use. If you're interested, I can let you know what we have at our shop. It's awesome. The tanks are always empty. We're always changing them. People are really finding the niche for it, and it works beautifully. You can use it for all of these indications and more. There's really only a few contraindications. And that's if the patient is struggling to breathe, they have severe pulmonary issue. Let's not put a full face mask on them, even though they will get 30% oxygen. There's also some studies that patients who have some vitamin deficiencies like B12, the nitrous oxide may inhibit the B12 from being made, so you want to avoid that. Any closed space with air in it is something that's a contraindication, so small bowel obstruction, sinusitis, or ear infection, because as the nitrous gets into the blood and the gas expands, you don't want anything to rupture. So you just want to make sure that there's no issues like that going on with your patients. Anybody who's just not with it, don't give it. Bad CHF or first trimester pregnancy. So at the end of all that I just said, my goal again is to evaluate situations in which opiates are really not the first line, and to move away from just giving opiates for all pain, and instead to really look at when we can use different medications and alternatives, and to also always educate our patients about what's out there and what different modalities they have. It really empowers our patients to talk to them, to engage them, and to help them know we're concerned about side effects and we want to try something different. In summary, if you see patients with these conditions or other painful conditions, this is some of the things that you can think about. You see emergence reaction when you get higher up on the ketamine continuum. So where I'm using ketamine is all the way at the bottom, a subdissociative or analgesic dose, which ranges from 0.1 to 0.3. When you're talking intranasal going up to 0.5, the 0.5 is towing on recreational, but because it's intranasal, it's not as bioavailable. So it's a similar, equal analgesic dose, if you will. So we do not have high incidence of emergence reaction at the 0.1 to 0.3, especially in the adults. We don't see that. Some of the literature talks about when you are giving the patients ketamine to let them know what's going to happen, what they're going to feel. They may feel a little out of body. They may feel a little disoriented, and to prime them for that. But we do not, as a standard, give any anxiolytic or benzodiazepine. If they, in fact, do have an emergence reaction, which should be as they're emerging from their dissociation, which they shouldn't have had at these doses, we will give something to take care of that.
Well, I use ketamine almost every day. I'm an anesthesiologist. So we've noticed that even with 15 micrograms or 15 milligrams in these people, which is extremely low if you don't pre-medicate them. And when you get up to the 25 and 50, they all, I'm just amazed that you don't have dysphoric reactions.
I have lots of Joe's people out here in the crowd. I don't know, Nilesh, Ashley, Otto. We use a lot of ketamine, and we do not see a lot of emergence, and we definitely don't pre-medicate. But the staff and the nursing and physician staff are aware that it is a potential, and that may happen. And if it does, we usually give about a 0.5 milligram of Ativan, but we do not, even in the children, not as frequently, maybe more frequently. And no, the answer is no. We really don't pre-medicate, and we haven't had much of an issue with it. And this is for pain, not typically for procedures, and again, very low dose. But thank you for the comment and feedback. Anything else?
For your headache protocol, you used a lot of IV.
Yes.
I work in a standalone urgent care, and your urgent care is attached to the hospital.
Yes, which I have a non-IV version.
So that's okay to substitute the IVs for IM. Is there any recommendation for like a standalone urgent care versus urgent care attached to the hospital?
The Cleveland Clinic algorithm was all intravenous driven, but I appreciate that there is not always a role to be putting the IVs in everybody you're seeing. So what our adaptation from that is to utilize everything PO and intramuscular. So the intramuscular Toradol we know is not much better than the PO ibuprofen anyway. So you can certainly do intramuscular if you want to. It may work a little quicker, but we know that the PO will probably be as efficacious. So Tylenol PO, NSAID PO, Reglan PO. The magnesium, whether or not you can give Mag-Ox and you have that available, I'm not sure, but prednisone 60. And then you can also give valproic acid PO and sumatriptan PO. So really there's PO formulations for a lot out there. It may take a little bit longer to work, but there's certainly a pathway for that, and it's not only going to be reserved for that acute inpatient patient.
Just a quick comment on emergence. The literature I've seen with high doses of ketamine for sedation, and I'm talking about 1 to 1.5 mg per kg, emergence reactions are fairly common, but the majority of them are not clinically significant. So they divide them up into clinically significant and non-clinically significant emergence reactions, and the majority of them tend to be you just talk the patient down, turn down the lights, put mom at the bedside. They don't need benzos. And the minority of them tend to be that they actually need something to take the edge off and sedate them. And that's my experience with ketamine is some people wake up with some emergence, but you can manage them pretty conservatively, and the majority do okay. But that's just my limited experience. I use it a lot for sedation in pretty high doses.
What do you do about this in a primary care office?
In a primary care office, I think there's a lot of, there should be a huge focus on patient education and also referring to pain management. So I think, I think most of us are working in an environment where we do have access to specialists. We're not the only doc for 50 miles. I think we have to appreciate that when patients get beyond what we're comfortable with, that we should move them on to a specialist, to someone who is comfortable. So if you've exhausted anti-inflammatories and Tylenol and physical therapy and topicals and osteopathic manipulative medicine, and they're still telling you they cannot function, they cannot live, then it's time to see what else we can do besides more pills. So things like epidural steroid injections, TENS units, things that the pain management specialists will discuss with them. They may not be options, but we should have the discussion. We should try to exhaust everything, because the answer so far has been, okay, NSAIDs, Tylenol, I'm not sure, Valium, Flexeril, not better, opiates. And so many people are addicted and dying from opiates. So they have a place, they're important, but I think we need to really think hard before we put a patient on opiates, because there's a huge percentage of patients started on opiates who will never get off them. If you start a patient on opiates for their chronic low back pain, the chances they will be on them forever. It's going to be really hard to take away what you gave them. So just be aware in primary care to sit down and talk with your patients, talk about tolerable levels of pain, all the alternatives, whether it's acupuncture, massage. Think outside the box. Let's try to get fancy. We just can't solely rely on opiates. And if the patients fail everything else, then go ahead and I think refer to specialists. Specialists have contracts. They do drug testing. They do PMP checks. That's what you need to do on patients on opiates, because they're just at high risk for addiction. The opiate is chemically similar to heroin. So the addiction potential is there. So just be aware that we have specialists. We want to do everything we can to avoid opiates because we're just in a crisis.
I have a question. Trying to get lidocaine patches for patients, it's like impossible.
I know.
They only do
I
it
know.
for shingles. And then my second question is, when you send people to pain management specialists, I've noticed that sometimes they do epidurals or injections, but a lot of times they just increase the opiates. So I'm always worried that, like, oh my God, what am I doing? I'm just making the situation worse.
Sure. Lidoderm patches, agreed. So lidoderm patches, you want to just kind of run into these pharmaceutical buildings and shake them. Lidoderm ointment, it doesn't have fantastic absorption, but you can try and use it. Voltaren gel, Flector patches. So oftentimes when I'm sending, especially a geriatric patient home later in the evening, I'll call the pharmacy, I'll let them know what I want them to go home on, and they'll tell me what's covered and not. And we'll go down the line of topicals until I can find one that is covered. Sometimes lidoderm is not, but Voltaren is, and other times Voltaren's $1,000 and lidoderm is covered. It doesn't make any sense, and I don't understand it. So I try, it's a little bit extra work, but you could just try and call and see what's covered. If not, you can also see about compounding pharmacies. Sometimes it's difficult, sometimes they can be expensive, but trying, also even over the counter, if patients have no issues, salicylate cream, like the Aspirin cream with lidocaine, you know, we write it off and we say it's not going to work. If there's no issues with salicylates and it's a couple days and can get them over that acute low back pain, it's worth a try. Your second question about pain management, you have to kind of vet your pain management specialists. What I would do if I had, you know, I know I'm going to have pain patients, I would go ahead and identify some of the pain docs in the area and give them a call. Hey, it's Dr. LaPietra. I'm having an issue with some of my patients. I want to refer them, but I do want to find out more about your practice. Can you tell me your algorithm of treatment? Can you tell me what you do for this? Do you do drug testing? Do you do pain contracts? Or ask your colleagues. Social media, it makes it very easy for us to collaborate as physicians. Throw up a post about anybody who's utilized some good pain docs in the area to get feedback, because you're right. Sometimes you're just adding fuel to the fire, but try and vet the docs in your area and develop a relationship so you can collaborate on your patient together.
Hi, how you doing? Actually, I'm a neighbor over at Chilton, across from St. Joe's. I applaud St. Joe's for taking such a program. Well, last night we attended an addiction program. Couple things. First off, in terms of admitting migraine headaches, that'll work at St. Joe's with residents. That won't work at a community hospital for observation with patient with headaches. Lidocaine is impossible unless you are diagnosed with, you know, herpes. You just can't get it, and it's very expensive. And St. Joe's gets a lot of money probably from the state, so your pharmacies are not on any type of monetary budget. And lastly, in terms of treating these patients with lidocaine in the emergency department, do you guys do drug screening? I mean, lidocaine is not a benign drug. Putting 2 or 3 patches on patients who may be benzo-withdrawing and at risk for seizures. I don't know if you've had, you know, seen a lot of seizures with lidocaine, but I have in 20 years of practice. People who come in who are withdrawing from something else or on medications, antidepressants that are prone to increase the seizure threshold. Slapping on lidocaine may not be the answer. Just the last comment is that, you know, emergency departments seem to be the place where this is an ongoing issue across this nation. And, you know, Joint Commission governmental agencies have to stop putting pain as a vital sign. That's one of the big key answers.
Jay Kaplan, the president of ACEP, just commissioned CMS to take pain scores out of patient satisfaction surveys. So that's that. I'm sorry about lidoderm patches. I'm sorry. I wish I could all give you lidoderm patches. I know. All I'm saying is let's try and exhaust other modalities. I know not all of them are realistic. And lastly, yes, intravenous lidocaine can be associated with seizures, and patients who have a history of seizure or who have alcohol withdrawal seizure, any kind of issue where you're concerned about their seizure threshold, then the alternative to opiate lidocaine is not the option. So intravenous lidocaine should not be given to everybody. You've got to screen your patients. But again, alternatives when appropriate. Let's just try just a little bit, and we may have a good outcome. Thank you.
I have
No,
one
one
last
more.
question,
Sure,
my dear.
I'm here.
Thank you.
Hi. So if these patients need to be admitted, do you see good adherence to these protocols once they leave the emergency room?
What I didn't mention in this talk because I didn't want to talk too long, was that we have collaborated with our departments of family medicine, psychiatry, physical medicine and rehab, and pain management, as well as 2 detox centers in Patterson. So when we started our protocol, we knew just this. So we see them in the ER, but we see them for a short period of time, and then they go out to the community or they go upstairs. So our chairman and our CEO met with all the department heads and had kind of a joint discussion about what we're going to do and how we're going to take this healthcare system wide. So the physicians are aware of what we're doing in the ER, and they have agreed to adopt a multimodal non-opiate approach whenever they can to continue this alto rhythm upstairs and outpatient. Did that answer your question? Oh, and the detox, we have recovering addicts who come into the hospital whenever a patient has an opiate overdose, try to engage them and get them into detox directly from ER discharge. And we also have agreements that we can see the patients back and forth from detox centers in the ER, knowing that we'll work to treat non-opiate.